Hello and welcome to Pharmacology. This is a brief overview over chapters 1 through 7, and then we have chapters 18 and 19, which will feature our adrenergics and adrenergic antagonists. So here we have the nursing process, and this is something that will translate throughout all of your subject matters when it relates to nursing. We always want to remember the nursing process or add PI as it relates to our drugs. So when we do add PI as it relates to drugs, we're looking at our assessment piece first, and that's all of our objective data. That is everything that we can see, everything that we look and assess with our physical eyes without the patient telling us is a part of our objective data. That could be anything from pulses, that could be our vital signs that we see, that could be even from pupillary responses. Everything that we're actually doing a physical assessment on would be our objective data. And then we also look at our subjective data, and that's everything that comes from the patient. So when we discuss subjective data, that can include everything from signs and symptoms that the patient is experiencing, how long the patient has experienced it, and just the duration and things like that. So again, when we look at our assessment piece on the nursing process, we're looking at subjective and objective data. This is really important when it comes to drug administration because sometimes this will lead us to either give a drug due to the signs and symptoms that a patient is experiencing, or it'll lead us to not give a drug due to the signs and symptoms that a patient is experiencing. And we are looking at our objective data pieces, especially vital signs, in order to make a determination if we should give said drug or not. So that is our assessment piece of the nursing process. Next, we have our nursing diagnoses. Now, in your textbook, it calls this something a little bit different, and it says it's a human needs statement. But again, this is known as our nursing diagnoses as it relates to API. So these is our set of things that we are going to guide our care as it relates to the patient. And again, nursing diagnoses are always care individualized and specified to a patient. So from our assessment, we move into our nursing diagnoses because these are the things that we're experiencing with this patient. The next thing that we're looking at is our planning or outcomes identification. So once we determine what the patient needs from our assessment data, once we develop our nursing diagnoses or human needs statement, we start planning. And these are outcomes that we plan to basically treat throughout our time with our clients or patients. Next, we have implementation, and this is the act of actually doing what we said we would do. So again, we move from the planning process to actually physically implementing what we want to do with the patient. So this is where the nurse is actually intervening on behalf of the patient in order to address the specific human needs statements or nursing diagnoses in this textbook. The next thing is evaluation. And of course, this is a cyclic process. So once we evaluate, we look and see if this has been effective or if it has not been effective. If said drug treatment has been effective, then we should see some sort of change in our assessment piece. We should see some sort of change in our vital signs. We should see some sort of change in the signs and symptoms that the patient is experiencing. So there's our evaluation, and then we reassess, and the process starts all over again. So again, this is the nursing process, and it's very important to know that this is a cyclical process, and it's something that is to continuously be done as we're administering our drugs. Next is pharmacokinetics, and this is the study of what happens to a drug from the time it is put into the body, whether it's through IV, whether it's through PO per os, whether it's through IM, intramuscular injection, whether it's through rectally, through the anus, whether it's buccally through the cheek. This is the study of what happens to a drug from the time it is entered into the body from either route of administration until it has metabolized and has left the body. So when we talk about pharmacokinetics, we split it up into several different portions. The first portion is absorption, and absorption is the movement of a drug from its site of administration. Again, that's your routes of administration, so IM, IV, PO, things of that nature, into the bloodstream for distribution to the tissues. Again, we are entering into the body through said route of administration, and then it goes to the bloodstream to be distributed to the tissues. Next, we will talk about distribution. So distribution refers to the transport of the drug by the bloodstream to the site of action. So when we talk about site of action, all drugs have a specific area or several areas even that it affects in the body. And this is where we should see our therapeutic effects or the desired effects from the drug. So the drug actually has to enter into the body through absorption, and then it has to be distributed through the bloodstream to the site of action. And again, there are areas where the drug affects multiple areas. So just make sure that you know that the body's multifaceted, is very dynamic. Drugs affect different parts of the body. You have your therapeutic effects, which is what is desired, and then you may have side effects, which also affects areas that the blood distributed this drug to, and they may not be as desired. But again, the blood has to carry the drug to the site of action. Again, you do have areas that have rapid distribution, such as the heart, and that makes sense because there's a lot of blood flow into the heart. There's a lot of blood flow into the kidneys, the brain. So you have to be mindful of how much of a drug is being administered because of this. It does affect these areas rather quickly. The areas of slower distribution may include muscle, skin, and fat, and that's just because there's a lot more area, surface area, and even thickness that this drug has to go through, and thus the bloodstream has to circulate through all of these areas. But again, once it enters the areas, again, circulation is what helps with distribution. So if you have an individual that has poor perfusion or poor circulation, then oftentimes medications are affected as a result of that. Next is metabolism, and this is also known as biotransformation. Once a drug is metabolized, essentially that means that it's more broken down, it's broken down into a more soluble compound, or it can be converted into a more potent and active metabolite, which can also cause either desired effects or side effects. Sometimes when a drug is metabolized, it becomes less active as time goes on, and we'll talk a little bit about that when it comes to half-life. But again, when we have metabolism, this is literally the physical process of the drug being broken down in the body. Now, two areas of the body that drugs are normally broken down is in the liver and also in the GI system, from the stomach down to the GI tract, and then it's ultimately excreted from there. So you do have drugs that love to be metabolized by the liver. You have drugs that love to be metabolized by the stomach. It just depends, but just know that both of these organs are heavily associated with drug metabolism. And then we have excretion. So excretion is the process by which you eliminate drugs. So we went from the drugs entering into the body through absorption, and then you have drugs that are distributed to the body through circulation. You have drugs that are broken down by metabolism, and then you have drugs that are excreted or eliminated from the body. And the way that the body eliminates drugs is normally through urine, or normally through defecation, or basically pooping. So if you have individuals that have problems with their GI tract, for example, excretion becomes very difficult because they're not able to move those contents that the body no longer needs out. Same thing with the kidneys. Kidneys are heavily associated with excretion because of the urinary component. So if you have individuals with kidney issues, chances are they may alter doses of drugs because the body, or they know that the body is not able to excrete the normal portions of those drugs. So it's very important to look at kidney function, GI tract function, things like that. People with paralytic ileus or bowel obstructions have a problem with excretion, so we have to be very careful with the drugs that we give them for that reason. The next thing we'll talk about is half-life. And half-life is generally the definition of the time required for 1/2 or 50% of the drug to be basically excreted from the body. So it is a measure of rate. So if you have 100 milligrams and the half-life is 50 milligrams, at an hour, it takes 1 hour for 50 milligrams of that component to be excreted from the body. So again, half-life is basically a time component by which excretion is measured. Next, we'll talk about medication class or drug classification. And this is how we group drugs together based on similar properties. It may be similar structure or similar therapeutic use. Either way, this helps us really narrow down how we identify drugs. So for example, our chart here has ACE inhibitors. Normally our ACE inhibitors are identified as prils. Prils have specific functions, which we'll go into at a later lecture, but just know that the reason why they are all labeled with the ending pril, or most of them have the ending pril, is because they have similar characteristics and they have similar therapeutic use. Same thing with beta blockers. Beta blockers specifically have lol on it, as our chart shows here. You see metoprolol, labetalol, propranolol. All of these are considered beta blockers based off of their function, and the name gives you the hint. Beta is a receptor that they actually inhibit or antagonize from the body. So metoprolol, labetalol are all classified as a beta blocker because they all affect betas or the beta receptor. So the same thing is such with all of these medication classes. You have calcium channel blockers, you have diuretics, you have angiotensin receptor blockers. All of these are considered within different medication classes, but that's because the effects on the body are very similar, and it is based on their therapeutic use. Next is our mechanism of action, and this is the way that drugs work, basically. And normally we look at the way drugs work based off of their therapeutic effects. When we discuss therapeutic effects, these are the desired or intended effects of a particular medication. So in the case of beta blockers, these are drugs that antagonize beta receptors, or they compete with epinephrine and norepinephrine to sit on the beta receptor. Now, we'll get into this a little bit later in this lecture, but just know that this is one of the therapeutic effects of beta blockers, but really we're discussing the mechanism of action, or how they work. So the thing about the mechanism of action is that normally these drugs stimulate or inhibit the natural function of those cells. When we talk about those receptor sites, for example, these receptor sites are naturally forming on our cell, as the chart shows. These beta receptors are naturally occurring on the cell, and the drug of choice here, which is beta blocker, the beta blocker sits inside of this receptor, and then it causes either the stimulation or the inhibition of this receptor. In this case, it is the inhibition. Normally, this receptor would accept norepinephrine or epinephrine naturally. So again, drugs either inhibit the natural function of the cell, or they stimulate the natural function of the cell. They don't make them do anything different outside of that. So let's talk a little bit about the autonomic nervous system, because this will be heavily related to the drugs that we'll be talking about later in this lecture. So with the autonomic nervous system, it is branching off into 2 points. And again, this is ultimately talking about the peripheral nervous system. So we have peripheral nervous system, and then what breaks down into the peripheral nervous system is the autonomic nervous system, autonomic nervous system, and then that breaks down into 2 separate nervous systems. We have the sympathetic nervous system and the parasympathetic nervous system. So it's important to know that this system innervates all kinds of areas in the body, from the pupils, heart, lungs, GI tract, urinary tract, skeletal muscles, skin, and even certain glands. So again, when we talk about our sympathetic nervous system and our parasympathetic nervous system, let's think of these as a balance between the two. Both of them must exist in order for the body to function appropriately, and they both have its strong suits, and they both have their negative suits. So we're going to dive into the sympathetic nervous system first. With the sympathetic nervous system, they it is stimulated by something that we call catecholamines. Those catecholamines are known as epinephrine, norepinephrine, and dopamine. So when we have the sympathetic nervous system, this is also known as our fight or flight nervous system, or our nervous system that helps us take in the environment more, to sense our surroundings. The reason why we say that is because what is happening when the sympathetic nervous system is stimulated. Anytime you stimulate the sympathetic nervous system, you have a few things that happen that I want you to remember. You have pupil dilation, so you can sense the environment. You have the heart that starts pumping more, your heart rate increases. And the reason why is because you have a positive inotropic effect, you have a positive chronotropic effect, and you also have a positive dromotropic effect. These are all things that increase, that help the heart pump more. So we have an increase in heart rate as a result. Then we have bronchodilation in the lungs. And what that does is that it helps the body get more oxygen to the systems that it needs to in order to either fight or flight. So again, we have all of these things that are happening with the pupils, heart, and lungs. As it relates to the GI tract, we actually see shunting of blood flow to the GI tract, and that is another way of saying vasoconstriction or sphincter contraction. The reason why is because in the sympathetic nervous system, we don't need our GI tract. We don't need that to fight or flight, but we do need our pupils, heart, and lungs at minimum to be able to fight or flight from the external stimuli. So again, we have the GI tract that is essentially shunted. We have vasoconstriction. We don't have a lot of blood flow down there. We have sphincter contraction because we really don't need the GI tract when we're in this system. Your urinary tract, specifically your bladder sphincter, is also contracted. And the reason why is because we don't need to think about using the restroom or peeing when we're in a fight or flight response. To the skeletal muscle, we have vasodilation. And again, when we talk about vasodilation, that's to help open that area up, particularly vasodilate, vasovessels dilate or opening, so we can get more blood flow to that area. If we're in a fight or flight response, that skeletal muscle needs more blood flow and thus oxygenation from that blood flow. That's a form of perfusion in order for the muscles to be appropriate for the fight or flight response. We have our skin that is vasoconstricted because we don't necessarily worry about our skin when we're fighting or flighting. And then our glands, we do have an increase in sweating because of all of the things that are happening. We may be running or we may be fighting, whichever. We do have a increase in our sweat glands. And then your pancreatic activity is going to go down. And if you know anything about the pancreas helps to secrete insulin, which helps to break down glucose. Well, this is not something, a time where we don't need our glucose stores. Insulin directly affects our glucose stores. Well, we actually need our glucose, and we need to start breaking that glucose down through the process of glycogenolysis so that we have energy to do all of the things that we stated above, to have our pupils dilate, to have our heart pumping, to have our lungs dilate, and hopefully have enough energy to activate that fight or flight or response. On the reverse side, though, we have the parasympathetic nervous system. Now, when we talk about the parasympathetic nervous system, we're not talking about catecholamines anymore. We're talking about something called acetylcholine, and that helps to stimulate something called muscarinic receptors. So with our catecholamines, they stimulate our alpha and beta receptors. With the parasympathetic nervous system, we stimulate muscarinic and nicotinic receptors. So with parasympathetic nervous system, we want to rest and digest. So as you can see, the parasympathetic nervous system is different from the sympathetic nervous system. In fact, they are total opposites. So as it relates to the pupils, we have pupillary constriction or pupil constriction. We have in the heart a negative ionotropic effect. We have negative chronotropic effects. We have negative dromotropic effects. With the lungs, you have bronchoconstriction and increased gland secretion. In the GI tract, you actually have more motility, an increase in your motility in your GI tract, also known as peristalsis. You have sphincter relaxation, and you have an increase in your gland secretion. Your urinary tract is now relaxed in the parasympathetic nervous system. Your bladder sphincter is relaxed because you can rest and digest and hopefully eliminate the things that your body is trying to digest. With your skeletal muscle, you don't really have any effects at all there. With your skin, you don't really have any effects. But as far as your glands are concerned, because you're resting and digesting, think about when you are eating Thanksgiving dinner, you have an increased salivation, you may have increase in lacrimation and an increase in pancreatic activity. You're trying to break everything down that the body has ingested and you want to process. So again, think about parasympathetic, para processing, sympathetic nervous system, you are fighting and flighting. Again, there are two different ways you can think about this. Sympathetic nervous system, fight or flight, parasympathetic nervous system, rest and digest, or sympathetic is related to getting everything processed. So here we have a therapeutic effect, and when we discuss therapeutic effects, again, this is the desired or intended effect of a particular medication. In our example on the right, we're talking about beta blockers. Specifically, this beta blocker is affecting the beta 1, B1 receptor, beta 1. So the beta 1 receptor is very specific to the heart, and the therapeutic effects that we're looking at is that it slows down contractility, it decreases it actually, and it slows down conduction through the AV node, which ultimately leads to a decrease in heart rate, a decrease in cardiac output. It also helps with a decrease in cardiac preload, which ultimately decreases our blood pressure and it decreases our O2 demand. This beta 1 receptor is also located on our kidneys. Now, here's a sidebar. Our kidneys are responsible for blood pressure, very so through the RAS cycle, or the renin angiotensin aldosterone cycle. Now, we won't get into too much detail with that, but just know that the kidneys do help regulate blood pressure. So if you have a beta 1 receptor on a kidney and beta blockers thus inhibit those beta 1 receptors, you will see a decrease in blood pressure from that aspect because it's affecting the kidneys. Now, when we affect the kidneys like this, you do have a decrease in renin, you do have a decrease in you have a release of aldosterone, excuse me, and aldosterone helps with water and sodium reabsorption. So when it affects that, you do have this natriuresis or release of sodium. And when that sodium is released, you have water and sodium excretion, which also helps to decrease blood pressure. So I'll run over that again. Your kidneys are responsible for blood pressure, and it does this through something called the RAS cycle. The RAS cycle is known as renin angiotensin aldosterone cycle, okay? So when it relates to the aldosterone, we're actually releasing this aldosterone, and it's not in abundance in the body anymore, which helps with water and sodium excretion. This is also known as natriuresis. Ultimately, when we don't have as much aldosterone in the body, when we don't have enough renin in the body, it ultimately decreases blood pressure. Okay, so next we'll talk about adverse effects, and this is any reaction to a drug that is unexpected and undesired, and it occurs at therapeutic dosages. So this is not something that where we have a high dosage or a low dosage and we didn't dose them correctly. This is an appropriate dose for said signs and symptoms that the patient has, and they're having side effects or adverse effects. So again, this can be bradycardia, hypotension, fatigue, dizziness, headache, depression, hallucinations, sleep problems, and libido and erectile dysfunction. Again, we are talking about the beta blocker that reacts on that beta 1 receptor that affects the heart. So let's talk a little bit about bradycardia and hypotension, because you may say, well, Miss White, the metoprolol or beta blockers are supposed to make your heart rate go down, and it's supposed to make your blood pressure go down. We just talked about the renin, angiotensin, and RAS cycle, and we just talked about what beta blockers do. So how is this a side effect? Well, it's supposed to make you go down into normal parameters. So our normal parameters for heart rate is normally 60 to 100 beats per minute. Normally with our blood pressure, we want to stay somewhere around 120/80, give or take, but that would be considered a normal blood pressure. So we're giving these medications because someone's heart rate is way too high, normally in the 130s or 120s, where it's supposed to be in the 100s and lesser, but not less than 60. As far as blood pressure, we give this to people whose blood pressures are extremely high in the 150s and 160s. So what the therapeutic effects are is that yes, it does bring down blood pressure. Yes, it does slow down your heart rate, but not to the point where you're having bradycardia. And when I say bradycardia, you can be bradycardic but not be symptomatic. So this has to be a very severe case where you start seeing signs and symptoms of symptomatic bradycardia, and that would include diaphoresis, that would include the dizziness, that would include just anxiety or feeling like you can't, things like that would be symptomatic bradycardia, and of course we would treat that appropriately. But when we say bradycardia and hypotension, that's under the parameters by which they are not normal. Unusual fatigue. You may be dizzy because you are hypotensive. You may have a headache because you are hypotensive. You may have both of those simply because you are bradycardic. You may see hallucinations. That's a central nervous system issue as it relates to low blood pressure and low heart rates. Or you may even have sleep problems or libido and erectile dysfunction. So again, when we talk about adverse effects, this is where we drop down so low in the case of our metoprolol here that we're seeing these effects that are not intended for the therapeutic effects. The main thing of this slide is that everything can be toxic. Too much of water is toxic. Too many drugs are toxic. And it's important to know that as a nurse, you're actually administering toxins or drugs that could potentially be toxic at too high of a dose. And most are safe at very low doses. But if you don't think about what you're giving, how you're giving it, why you're giving it, you run the risk of overdosing someone or giving an unintended dose or giving a dose that is not intended for that patient, and you could cause toxic effects. So as this quote says, all things are poison and nothing is without poison. The dosage alone makes it. So a thing is not a poison. This is sola dosis facit venenum by Pericles. So we say all that to say this. We do look at the peak level or the highest level of blood in a drug. Well, drug in a blood. We look at the trough level. This is the lowest level of drug in the blood. So when we look at peaks and troughs, for example, with antibiotics and particularly vancomycin, we look to see how much level is in the body after we have dosed an individual so many times. And normally these are checked at increments as prescribed by the provider and in this case by the pharmacy, because normally they do look at things like this. We don't want to get to a point where a trough, or as in this case a vancomycin trough, is too high, because that means we're giving too much of the drug. If we have toxicity, this is the level at which the level of drug occurs if the peak of the blood is too high. The peak level of the blood is too high. So again, when we look at peak and trough, it is a toxicity issue, and it helps us know if we've given too much or too little, and then we can dose appropriately from that. So, when we talk about toxicity, this is again the condition of producing adverse effects because of the level of drug that is in the body. So, in the case of beta blockers, if we have too much of a beta blockers, particularly those that are non selective beta blockers or selective to the beta 2 beta blockers, at high doses, we may see side effects and adverse side effects such as bronchoconstriction or bronchospasm, which can lead to shortness of breath or dyspnea. After that, you may even see certain other metabolic changes such as hyperglycemia. And think about why we might see hyperglycemia. That's because when we have a sympathetic response, when we have agonistic effects, agonists, we have a breakdown of our sugars because we need energy for the fight or flight response. Well, the beta blockers work opposite, and because it's not blocking or because it's not producing an agonist effect, it's an antagonist, it will actually have the reversed effect. We're not breaking down sugar anymore for energy. We're actually holding on to sugar because of the antagonistic effect of beta blockers. So you will see hyperglycemia, you will see hypertriglyceridemia, edemia, and you will see versions of hyperkalemia. And again, that has a lot to do with that sodium potassium pump that's in our kidneys, and we're not having a lot of sodium excretion, and we're holding on to the potassium. So again, you have things that can be toxic due to the level or high dose level of medications. Again, the beta blockers and the selective beta blockers, non-selective and selective beta blockers, these are just an example of what can happen as a toxicity effect. These are our drug interactions, and this is the alteration in the pharmacologic or pharmacokinetic activity in a drug that is caused by the presence of one or more additional drugs, food, or dietary supplements. It's normally related to the effects of the enzymes required for the metabolism or breaking down of said drugs. So, for example, in our chart here, we have different foods that actively react with different medications. For example, we have leafy green vegetables and they react with warfarin. The result is decreased anticoagulation effects from warfarin because warfarin is an anticoagulant. So the reason why is because leafy green vegetables generally have a high amount of something called vitamin K, and vitamin K actually directly antagonizes warfarin. So it would have a decreased effect for that reason. Dairy products, same thing. We see a lot of interactions with dairy products and antibiotics. We have the levofloxacin, we have tetracycline, moxifloxacin. All of these are antibiotics. And again, the result is the chemical binding of the drug leading to decreased effect and really treatment failures because of this binding. So dairy products do react a lot um, with our antibiotics. Grapefruit juice reacts with all kinds of things. It reacts with amiodarone, which is an antidysrhythmic for your heart. It interacts with carbamazepine, which is an anti-seizure medicine. It can react with calcium channel blockers, nifedipine, nisodipine, all of these calcium channel blockers. It can react with our statins, which is our cholesterol drugs. It can react with immunosuppressants such as tacrolimus. Grapefruit juice reacts with all kinds of things, but really what grapefruit juice does overall is that it decreases the metabolism of drugs, and it also leads to increased effects with some. We won't go into the details with each one of these classifications of drugs, but just know that grapefruit juice really reacts with a lot of things. Aged cheese and wine definitely reacts with something called monoamine oxidase inhibitors, and this is one of our psychiatric drugs. Again, we won't go into too much detail about why, but just know that the result is hypertensive crisis. So again, it is really important to do that add pie piece, that assessment piece, and find out what types of foods that your patients are eating because if they're on certain medications or if they're coming to you experiencing certain signs and symptoms, your first thought should say, hey, what kinds of drugs are you taking? But also, what other foods are you eating in combination with those drugs, and see if you can narrow down why they're having such aggressive effects with certain medications. Next, we have our contraindications, and this is any condition, especially those that are related to disease processes or pathophysiology, that makes drug therapy improper or undesirable. So, what that means is that we don't give certain medications to individuals that have certain conditions. For example, we've been talking about beta blockers all this lecture, so let's go with that. With beta blockers, we don't normally give a beta blocker to an individual that has a heart rate that's less than 60 unless the provider orders a specific parameter, and they may allow us to give it if the individual's heart rate is at 55 at certain doses. So we don't give beta blockers to individuals with bradycardia. We don't give beta blockers to an individual that has a blood pressure of 80/40. The reason why is because it'll further cause these adverse effects, but more so toxic effects that could cause other issues with the patient. We also don't give it with decompensated heart failure. We don't give these medications to these individuals because it is called a contraindication. So you have to pay attention to this in your assessment process to make sure that your patient is optimal, and just know that this can change at any point during your shift. What may be appropriate for your patient during one part of the shift, for example, with their blood pressure, maybe they did come in, or you came in and their blood pressure was high. So you gave them their first dose of beta blocker for the evening or for the day. And then you come back and their blood pressure is way low, lower than what you came in with. So obviously the beta blocker worked, but it may not be appropriate to administer that second dose. So at that point, you would need to contact your provider and make sure that they're still okay with you giving a medication, or maybe they want to reduce the dose, or they may want to do something else regarding this patient's heart rate or blood pressure if it's a scheduled dose that's due. They may even say, no, just hold it for today and we'll reapproach at the next dose. So you have to consult with your provider when you see these contraindications, because there may be different areas of therapy that they can have as a replacement. So let's look at this again. This is your nursing process in a nutshell. When we look at our nursing process, you always want to get a baseline assessment. You want to look at your vital signs, look at your lab test and results, because there may be an excretion problem. So we may need to look at our renal function and our hepatic function. We may need to look at our electrolytes, particularly our sodium levels and our potassium levels, depending on what kind of medications we're given. We want to look at our blood glucose levels and our lipid panels to see if certain medications are appropriate to give or not give. Next thing you want to consider is if we are giving certain medications, what's the status of their hypertension? What about angina? What types of arrhythmias are they experiencing? And does the patient have heart failure in this case? So we're looking at our baseline assessment, we're doing our physical assessment, and we're looking at vital signs and lab results as a result of that. When we look at patient education, we want to make sure that we, one, make the medications and drugs that we administer to them easily to understand. Sometimes we talk in such a level that patients don't necessarily understand hypertension, but maybe grandpa or grandma, maybe they understand high blood pressure, or maybe they understand low blood pressure, but you can't say terms that are harder to understand. So you want your teaching to be patient-centered, and you want them to be health literate. You want to always provide educational opportunities, and really nursing tip, NCLEX tip, discharge planning always starts at day one, because we don't want to hold anybody there forever. So again, discharge planning always starts at day one. You want to make sure you consider that communication barrier. Maybe a patient is able to understand, but maybe they can't communicate very well. Again, you want to keep things simple as possible. Make sure that the care that you give is focused on the patient's health needs. Oftentimes we have a generic plan with our patients, but really we need to be individualized and focus on that particular patient. And it could change even if the patient has similar pre-existing conditions or comorbidities. It still doesn't mean that you cannot individualize their care plan, because sometimes individuals suffer more with certain parts of their comorbidities than others. And you always want to empower your patients to become active in their care, and always offer those opportunities to teach them, learn, make sure they're able to identify certain things. Because again, when they're not under your care, they're by themselves or with a healthcare individual or a care partner. So if that is the case, not only educating the patient is important, but it's also important to educate who's taking care of them as well. So again, you want to focus on understanding how the medication helps, and you also want to teach them to take the medication exactly as instructed, and never to stop their medication abruptly without a provider's discretion. So when we talk about medication errors, that is basically anything that is a preventable event, because we're the ones that's giving it. So technically, medication errors can be preventable, because we should be so prudent and so watchful over medications that we do not cause inappropriate use or harm from medications. So again, medication errors are preventable. As this chart notes, is that these are everything that we can see with a wrong patient error. So we have wrong rates, wrong time of administration, medication that has been omitted, wrong doses, wrong fluids, wrong drugs, wrong route, wrong patient. And what's at the top of this list is wrong rate, and that would apply mostly to our IV fluids and drips. So it's really important to make sure that we do all of our checks. All of these wrong things are technically our patient rights that we can look at. It's supposed to be right patient, right route, right drug, right indication, right time of administration, right rate or dose. Um, all of these things are associated with our patient rights to medication administration. So as you can see, when we don't follow that, and when we don't check, when we don't do our two-person identifier, even name and date of birth, make sure we're scanning, make sure that we have the appropriate administration. I mean, even if we scan, sometimes you have to look at the medicine and make sure it is the actual right dose. So you have to look at those things, because there have been errors, even per the pharmacist, that either put the wrong label on the medication or the wrong concentration of the medication, all kinds of things. So you have to be prudent in what you're administering, because again, medication errors are preventable if we do the correct checks. And again, you have to look at this, and can't skip over things, can't take shortcuts when it comes to medications, because as you can see, we do have issues that arise from that. I know many of you remember the Redonda case. Well, that was a prime example of this. So if you are administering a medication, it does not take you but 2 seconds to scan everything. It doesn't take but a few minutes to make sure that you have the right medications. Make sure you identify the patient. Make sure you scan that wristband prior to giving the medication. Make sure that you're administering it at the proper doses. Make sure you're cutting your pills in half that need to be cut in half. Make sure that you're drawing up your medication according to what the dosage requirements are. All of these things are things that you can do to help prevent medication errors, and you have to be prudent when it comes to being a nurse in that. So here's our first drug class that we'll talk about. We're going to be talking about adrenergic agonists. And when we talk about an agonist, this is something that is stimulating a response. And as it relates to adrenergic class, these are medications that stimulate the sympathetic nervous system, or the sympathetic response. Another word for adrenergic is also known as sympathomimetic. So if we say adrenergics, adrenergic agonist, sympathomimetics, we're talking about the same class. So earlier in this lecture, we talked about a lot about the differences between the sympathetic nervous system, fight or flight, and the parasympathetic nervous system, rest and digest. Well, we have something called neurotransmitters, also known as catecholamines, that help produce a sympathomimetic response. So when we talk about catecholamines, those are three different neurotransmitters. That's your dopamine, epinephrine, and norepinephrine. These are all collectively known as catecholamines, and they help stimulate the sympathetic nervous system response. So when we have a norepinephrine neurotransmitter sit in a alpha or beta receptor, which is something that receives norepinephrine or epinephrine, it helps to stimulate those higher heart rates, those pupil dilations, the bronchodilation. This is what helps stimulate that response. So when we talk about sympathomimetics, these are substances or drugs that mimic the actions of the neurotransmitters epinephrine, norepinephrine, and dopamine. So as we have stated before, the activation of our sympathetic nervous system is our fight or flight response. You'll normally see an increase in heart rate and blood pressure, increase in bronchodilation. You'll see pupillary dilation. That is the widening of those pupils so you can sense the environment. And then you'll see a decrease in digestion because we don't need our digestive system or our urinary system at this point. And ultimately what it does is that it maximizes blood flow to our muscles, our skeletal muscles, and our brain. So as I've stated earlier, we have catecholamines, and catecholamines are ones that, and specifically epinephrine and norepinephrine, they rest on receptors. They have to bind to these specific receptors or adrenergic receptors in order to stimulate that sympathetic response. So we have alpha receptors and beta receptors. So with our alpha receptors, those mostly work on our blood vessels. When we have our beta receptors, they work on our heart and lungs and other areas of the body. So the first one here is talking about our alpha 1 and alpha 2 receptors and even beta 2. The blood vessels are stimulated to vasoconstrict in the gastrointestinal tract, but they vasodilate in the skeletal muscle and the brain. Remember, I discussed that when you have the stimulation of the sympathetic nervous system, it increases blood flow to the skeletal muscle and the brain. Well, the reason why there's vasodilation is because you're trying to get more blood flow to this area so you can have more of a fight or flight response. The next receptors, we have the heart, and the heart has alpha 1 receptors on it, and it also has beta 1 receptors on it. Now, alpha 1 receptors can appear anywhere in the body, or really alpha receptors can appear anywhere in the body. Beta receptors can appear anywhere in the body, but specifically when we have these neurotransmitters or drugs, sympathomimetics, adrenergics, bind to the alpha 1 receptor, that bind to the beta 1 receptor, we see an increase in heart rate, and we also see an increase in contractility. Next, we have our lungs, and that is more affected by the beta 2 receptor. And again, we're stimulating that fight or flight response. So we have to get more oxygenation to the blood. We have to get more, well, to the lungs. We have to get more blood flow to the lungs. When we increase blood flow to the lungs, we increase oxygenation to the cells, what helps with that fight or flight response. So we have bronchodilation so that with each breath, the body gets more oxygen to help with that fight or flight response. When we have our salivary glands, we do have a decrease in saliva production because we don't need that if we're in a fight or flight response. Same thing with our liver. We see an increase in glucose and particularly glycogenolysis. So we're breaking down this glucose from glucagon to glucose in order to increase the amount of circulating glucose that helps increase our energy needs. Then we have our pupils. Our pupils dilate so we can sense the environment, and this is affected by our alpha 1 receptor. With our bladder, these detrusor muscles are relaxed when stimulated, alpha 1, alpha 2, beta 3. Our skin, we have the increase in sweat. Now, this is a muscarinic response, and we're not necessarily going to go into the ins and outs of that. And we're not necessarily going to go into the ins and outs of ejaculation or uterine relaxation, but really the main thing you should take away from this slide is the blood vessels. You have that vasodilation in the skeletal muscle and in the brain. You have vasoconstriction in the gastrointestinal tract because you don't need that. You have an increase in heart rate and contractility. You have an increase in bronchodilation and a decrease in saliva production, and also an increase in glucose because the body needs more energy. Again, that process is called glycogenolysis. So make sure you commit this slide to memory, or just make sure you review it, because it'll help you understand what these adrenergic receptors are doing and how they help the body stimulate the fight or flight response. Okay, so let's talk a little bit about these drugs. And again, these are adrenergic drugs, but specifically, these drugs work on our alpha receptors. So these are specific to our blood vessels, mydriasis, so we have pupil dilation, we have urinary retention, and we also have ejaculation. So when stimulated, these things, and I really want you to focus on the blood vessels, pupil dilation, and urinary retention. These alpha receptors are stimulated by the drug midodrine, phenylephrine, and norepinephrine. So let's talk a little bit about midodrine. Midodrine is a PO version of an alpha adrenergic, and it helps to stimulate these responses. But really, we give midodrine as a first line response to hypotension. That's not awful, but we want to get a patient's blood pressure up. We may even give this to someone that is a renal patient that's getting dialysis and may not necessarily tolerate dialysis well. The reason why we would give this for dialysis is because normally we're pulling fluid off of an individual, which thus decreases their blood pressure. Some people respond to that very poorly. So by giving them midodrine, we help keep their blood pressure boosted in light of them having dialysis treatments. Now we have phenylephrine and norepinephrine. These are IV versions of an alpha adrenergic. And again, they specifically work on the blood vessels. They work with your pupillary dilation, and they work on urinary retention. Your alpha 1 receptors work on these things. Okay, so phenylephrine and norepinephrine are similar to our catecholamines, epinephrine and norepinephrine. Notice that levofed norepinephrine has the same name as the neurotransmitter norepinephrine. But if you still kind of had some confusion about it, just look at the end of the word. It says ephrin, phenylephrine, norepinephrine. So when we look at these ephrins, or in this case phenylephrine, norepinephrine, they still have the same effects on the body. You do see blood vessels that they work on. You still see the mydriasis. You still see the urinary retention. But think about what's happening with the blood vessels. We do have some vasodilation that is happening with our blood vessels. We have our pupils that dilate, and we have urinary retention. Again, when we have alpha adrenergics, this is what they work on. Now, the nuance with neocephedrine or phenylephrine and levofed norepinephrine is that these are IV medications. So it is not sustainable for us to continue an individual on an IV medication. What we normally do is we see the signs and symptoms of an individual that needs an adrenergic stimuli. We'll put them on the norepinephrine for a little while, levofed as a first line defense for low heart rate, low blood pressure, to get them up to a certain level. Once they hit those normal parameters and have sustained the normal parameters, we do try to wean them off. And the reason why we try to wean them off of that is because if we constrict too much, we do see our peripheral limbs, the arms and the legs, start to change color and have adverse issues with that because it's working on these areas. So again, PO, midodrine, is our first line of defense, but when it's a severe case, you will see us pull out levofed or norepinephrine or phenylephrine, neocephedrine, in order to help treat those pressures and those heart rates. Here's a really good slide that relates to our beta adrenergics. So we just talked a lot about our alpha adrenergics and what they affect. Well, our beta adrenergics, in particular, these drugs affect these areas. So we have the heart and kidney for the beta 1. And most of the drugs that do that is called dopamine, dobutamine, and norepinephrine. So we saw norepinephrine on the alpha adrenergic slide. So what you can say is that levofed particularly is non-selective because it can affect alpha adrenergics and it can also affect beta receptors. So again, we have levofed that is non-selective. We have dopamine. This is also known as entropin, and you also have dobutamine, Dobutrex. These affect our beta 1 receptors. Now, the thing to remember about our beta 1 receptors is that they're specific to the heart. So beta receptors, particularly our beta 1 receptor, we have one heart, so they're more specific to the heart. And they are also featured on the kidney, and we talked a lot about that with our beta 1 blocker earlier in this lecture. So again, we have the heart that is affected by beta 1, one heart, and the kidney is also affected by this. So again, we have all of these drugs, dopamine, dobutamine, and norepinephrine that affects that. The next one we have is albuterol. Notice that this affects beta 2. We have two lungs, so beta 2 affects the lungs. And we have different drugs that affect that, such as albuterol, and that one should be familiar because of our inhalers. You have levalbuterol, and it looks exactly like albuterol, works the same way. And then we have salmeterol, and that also works on that beta 2. So under no circumstances should you say that albuterol, levalbuterol, or salmeterol affects the beta 1 because that's the heart. These drugs affect beta 2 receptors, which are specific to the lungs. So it does help with bronchodilation in the lungs, and it also helps with the muscles. And then we have our mirbetriq or mirabegron, and that one works on beta 3, and particularly our adipose tissue. Again, this is one that is not commonly used, and in fact, they are, still doing research on it and seeing how it affects the body. But again, beta 3 does affect the adipose tissue. So a way to remember our alpha receptors versus our beta receptors is that alpha receptors constrict, beta receptors dilate, or they help to beat. I'll say that again. Alpha receptors help with constriction, and then beta receptors help with dilation, or they help with beating. Now, when we talk about beta 1 receptors, there are things that I want to discuss with you, particularly with the stimulation of the heart. So we have things called inotropic effect, we have chronotropic effect, and we have dromotropic effect. So it's really important to know these terms because we can have a positive effect in all of these areas, or we can have a negative effect in all of these areas, and we will talk about that in some later slides. But when we're talking about ionotrope, this is really a force of contraction. This is the contraction and how forcefully that heart is contracting. This is dealing with our beta 1 receptors. You also see increase in heart rate chronography, chronologically. Chrono is a measurement of our heart rate, which is a time component. So we have ionotrope, which is the force of contraction. We have chronotrope, which is the time. We have our heart rate. We measure that through measuring the pulse. And then you have increased conduction or dromotropic effects. This is the conduction or the electricity that flows through the AV node. Now, we're not necessarily going to go through the different parts of the heart, but just know that there is an electrical conduction system. One of them is called the AV node, well, the SA node, which is our pacemaker, and then a little bit further down, we have our AV node, and that also helps with contractility of the heart. more oftentimes when people have heart failure, their SA node has failed. So we're trying to stimulate their AB node to start beating more effectively. So this is something that we're trying to cause a positive dromotropic effect. So again, make sure you remember the 3 effects of beta adrenergics, particularly the beta 1 adrenergic. And this is ionotropic effect positive, we have chronotropic effect positive, and we also have dromotropic effect positive. So here's just an overview of your heart. And again, this is really talking about how your heart contracts and how we calculate our heart rate, or how we quantify that. So the thing is that we normally have our electrical current starting through that sinoatrial node, or our SA node. This is also known as our pacemaker. And then say if our pacemaker or the SA node fails, it then moves down to the atrioventricular node, or your AV node. So you start seeing this in people with heart failure. Their heart doesn't pump as efficiently, and part of the result of that is your SA node, or the pacemaker in the heart, is starting to fail. So you have your AV node that will pump and conduct that electrical current, and then that will thus become the new pacemaker of the heart, and it keeps going and going until the heart completely shuts down and fails. So it'll travel through that AV node, the electrical current, and then if that doesn't work, you have the bundle of His that becomes the new pacemaker. And then if that doesn't work, you have your bundle branches, and then the Purkinje fibers that'll hopefully conduct your heart rate. But the thing is that when we start at the sinus atrial node, or that SA node, here on the right, you see where it says sinus node in the yellow on the right. That is where the pacemaker starts in the heart. Normally in heart failure, that pacemaker, or the sinus node, has started to fail, and then we are heavily dependent on that AV node. Well, the sinus node has an intrinsic heart rate or pulse of 60 to 100. When you drop down to that AV node, the new heart rate or pulse that comes from that is 40 to 60. And then after that, from 40 to 60, it jumps down to 40 or less than 40 as we move down the bundle branch and into the Purkinje fibers. So what all of that is saying is that this is how the heart is pumping. This is the conduction of cardiac impulses, electrical impulses through the heart. So why do we talk about this? Well, if we have a beta 1 adrenergic receptor, it is stimulated by adrenergic drug. Again, we have the increase in the force of contraction, which is your positive inotropic effect. You have an increase in the heart rate, positive chronotropic effect, and then that part that we were talking about with the electrical current, that is where our positive dromotropic effect occurs, and specifically it occurs at the AV node. Again, it doesn't necessarily affect that sinus node, because the heart is normal when you're pumping from the sinus, or have your electrical currents coming from your sinus node. It really affects the heart at the AV node area, and that's where we're trying to get more pumping going, because, or at least more nerve impulses going, because the heart is in a state where it's not conducting electricity appropriately. So up until this point, we've talked a lot about different adrenergic receptors. Those are those alpha receptors and those beta receptors, and they're more oftentimes stimulated by drugs that resemble epinephrine and norepinephrine. The next receptor type that I want to talk about is the dopaminergic receptor, and if you could take a wild guess, it helps to stimulate, or it's stimulated by dopamine. Again, norepinephrine, epinephrine, and dopamine are all catecholamines, but dopaminergic receptors are only stimulated by dopamine. So when stimulated, the receptor with these dopaminergic receptors, they stimulate the renal vessels, they stimulate the mesenteric vessels, and they also stimulate the cerebral arteries and the coronary arteries, which ultimately causes all of these artery types to dilate. This ultimately increases the blood flow to these tissues. And again, dopamine is the only neurotransmitter that can stimulate dopaminergic receptors. Now, you have dopamine and then you have dobutamine. So, dopamine and dobutamine are very close in their chemical relationship. They're very, very similar. But in clinical practice, its main action, dobutamine's main action, is on beta 1 adrenergic receptors. Therefore, dobutamine does not affect dopaminergic receptors. So it's similar chemically, it stimulates similarly, but the thing is that it does not activate that dopaminergic receptor. So do not get that confused. You have dopamine that stimulates dopaminergic receptors, but you have dobutamine, but it does not stimulate those dopaminergic receptors. So that would be the difference. So what are we saying? Dobutamine, its main action is on beta 1 adrenergic receptors, which means that it stimulates the heart. It will help increase contractility. It will help with that chronotropic effect. It will help with the ionotropic effect, and it will also help with your dromotropic effect. It has positive effects in all of these areas. But again, it does not have any effect on your dopaminergic receptors. So this is a really good slide that just kind of gives you an overview of all the medications that we just discussed. So most of the medications that we discuss in our adrenergic category are called vasoactive medications. And it's important to know that these vasoactive medications are things that we titrate. This means that we have to have continuous EKG telemetry monitoring on these medications because the body can change so drastically when these medications are administered. The other important thing to remember about these medications is that they are mostly administered via IV. So again, there's that importance of being able to have continuous monitoring, particularly telemetry monitoring and blood pressure readings, even oxygenation readings, heart rate readings. We have to have continuous monitoring of that because the body will change in relation to the amount or the dosage that is administered with these medications. We don't ever shut these medications off abruptly because these are titratable. That means we have to do something called weaning. We have to get the body used to not having this drug in itself because of what they're doing to the body. These are adrenergics, so they're stimulating heart rate, they're stimulating blood pressures and things along those lines. So if we abruptly stop these medications, or if it gets cut off by accident, or if our bag of fluid runs out with this medication, we do see adverse effects and we can even see clinical death as a result of that. So we have to wean or slowly decrease the amount of dosage of each of these medications in the body in order to have a positive and a better response. We titrate up in order to get the body back to where systemically you have appropriate heart rates and blood pressures, but also when we're trying to take the body off of these medications because it is not sustainable for anyone to be on these for a long term. This is where we start the weaning process. So take a look at this slide and just note the receptor types, note where they act. Norepinephrine specifically, or they call this noradrenaline. This is something that works on your alpha 1, it works on alpha 2, and also beta 1. We have adrenaline here, which is epinephrine, and you can see this in the form of EpiPen and things along those lines, which is an IM injection. But you see the receptors that it works on is alpha 2 and beta 1. So both of these would be non-selective because they stimulate two different types of receptors. Now, don't necessarily pay attention to the dose. We're not necessarily testing you on the dosage of your of your medications here. What we really want you to understand is what is it doing to your blood pressure and your heart rate, and how does that look systematically. So again, we can give phenylephrine, norepinephrine to increase blood pressure. Norepinephrine specifically will increase contractility and cardiac output and systemic vascular resistance. We normally give epinephrine to increase contractility, cardiac output, heart rate, blood pressure, and systemic vascular resistance. We normally give dopamine to increase heart rate and blood pressure as well, especially in the case of symptomatic bradycardia. When we talk about symptomatic bradycardia, that is where you see signs and symptoms in addition to someone having a low heart rate. So you have athletes that can have a heart rate of 50, 55, and they have no signs and symptoms of a low heart rate. They just have it, and that's where they exist because they're an athlete. In the case of someone that's symptomatic, you may see that paired with sweating or diaphoresis, or you may see that paired with someone that has dizziness, or they may go into a coma for some reason. You have symptoms that are associated with the bradycardia, so you can't necessarily give dopamine to someone that has a low heart rate simply because they have a low heart rate. You have to have symptomatic bradycardia. And then we have dobutamine, which is chemically similar to dopamine, but it does not stimulate the dopaminergic receptors. Again, dobutamine stimulates the beta 1 receptors. So we have that contractility that's increased. We have an increase in cardiac output, an increase in stroke volume, increase in heart rate. So just make sure you take a peek at these and just look at the pertinent particulars as it relates to those different medications. So here we have our slides on pertinent particulars with our medications. As you can see, we've pointed out phenylephrine and midodrine here. In the case of phenylephrine, you may recognize this as neosynephrine, and this is a short-term medication to raise blood pressure, but they also have used this as an ophthalmic solution, which goes in your eyes, and also a nasal decongestant, but they found that this has not been very effective as an over-the-counter decongestant, so they may be progressing to move this off the market. If you have phenylephrine, it may cause symptomatic bradycardia at high doses, and it may also worsen heart failure due to the increase in afterload. As far as midodrine, it is given by mouth, and again, this is given several times a day, and most often we give this to renal patients that cannot tolerate their hemodialysis treatments. Again, we give dialysis treatments to help pull fluid off of a dialysis patient because their kidneys are not able to excrete fluids very appropriately. So when you pull fluid off of an individual, you thus decrease their blood pressure. And in absence of midodrine, you may see them get a condition called orthostatic hypotension. Orthostatic hypotension is just the process where you change positions, whether it's sitting to standing, and your blood pressure drops, hence hypotension. Orthostatic is change in position, low blood pressure, hypotension. So you increase the risk by giving that. By not giving it. So we give midodrine to help increase blood pressure so we don't see orthostatic hypotension in these patients. You may also give this to patients that are at risk for supine hypotension, which is just hypotension when they are laying down. So again, midodrine is given a little bit more frequently because it's a PO drug, but it does help with orthostatic hypotension and supine hypotension. The issue with vasoactive adrenergics is that most of them are given IV. So if it's given IV, normally medications given intravenously are quickly, the body quickly responds to that. So if we're giving that, again, we have to have them on continuous monitoring, continuous telemetry or electrocardiogram monitoring, because we have to look at the medication and adjust it up or down appropriately according to our provider's orders. So here are those vasoactive drugs again, and we have these two that are non-selective adrenergics. So before we talked about some selective adrenergics, now we are talking about non-selective vasoactive adrenergics. Non-selective meaning that they act on both alpha receptors and beta receptors. Now, Levofed is norepinephrine, and it's indicated for hypotension. And normally we use this as a first line treatment for septic shock. As a crash course in septic shock, that's normally clinically characterized as a low blood pressure with a high or low heart rate. But normally it's a relation to a bacteremia or a bacteria that has circulated in the blood and has caused an infection, and now the body is responding with shock because it cannot fight off that infection. So we do use Levofed for septic shock, and we also use this particularly as peripheral vasoconstrictor and as an inotropic stimulator. Remember, inotropic increases the forceability of that heart contraction, and it also dilates your coronary arteries, which is your beta adrenergic action. We have adrenaline, also known as epinephrine, and normally we give these to people that have anaphylaxis. And if you have anaphylaxis, that is a severe allergic reaction. We also use this in cardiogenic shock, which is another form of shock, again, that is characterized by low blood pressure, but in this case, the heart is more heavily involved. We don't necessarily have to get into the ins and outs of that, but just know it's more heart related. Or it may be indicated for cardiopulmonary arrest, or this is basically dying. The heart has stopped, and we use epinephrine to jumpstart the heart. We use it to help open up, for in the case of anaphylaxis, we help redilate those lungs so we can get oxygenation into the patient. We use it in cardiogenic shock to help boost your pressures because you are in a shock state. It is normally used as a vasopressor, and we normally use it in the ICU for that reason. Hemodynamics is normally just monitoring the heart rates, blood pressures, vital signs as it relates to the response of these medications. You do have to titrate this appropriately. And again, I stress to you that it requires continuous EKG, ECG, or telemetry monitoring. Now, when you are giving epinephrine or norepinephrine, you should observe for heartbeats or ectopic heartbeats. This is known as your weird heartbeat. So this is considered a PVC, premature ventricular contraction, or a PAC, premature atrial contraction. You want to listen for hypoactive bowel sounds. You want to look for peripheral ischemia, because if an individual is on these medications very long, it can actually cause the change of color in the periphery or in your extremities. It can cause hypoactive bowel sounds, which means that your bowels have shut down. And that makes sense, because if these are medications that stimulate the fight or flight response or your adrenergic responses, the body is thinking that it does not need its bowels and it does not need its urinary functions at that time because it's fighting or flying. But long-term use causes these things, and it causes these areas to shut down and have poor outcomes. So you do want to make sure you look for those things, and such as in the case of vasospasms or myocardial infarctions. Okay, so here's our vasoactive adrenergic inotropes. So the first one we'll talk about is dopamine. And again, the thing about dopamine is that it specifically acts on the dopaminergic receptors, but it can act on alpha receptors and beta receptors, but only dopamine can activate dopamine receptors, okay? So it can function in all three categories, which means that it's non-selective. It's normally used as a second line agent in most forms of shock, that's septic shock, cardiogenic shock, neurogenic shock, all kinds of shock, hypovolemic shock, all kinds. So with dopamine, just remember that it can cause positive inotropy, which is the forcibility and contractility of the heart. It causes positive dromotropy, which is the increase in the electrical current or your electrical contractility in the heart. And then you have that time component, which is the heart rate or pulse. It has a positive effect in there. Versus dobutamine, it only acts with inotropy, the forcibility of the heart, and mild vasodilation. It only acts as a beta agonist, specifically a beta 1 agonist. So dopamine and dobutamine are chemically similar, but dobutamine can only act on your beta receptors. So that is the difference between dopamine and dobutamine. If you get those confused, just look at dobutamine as dope, but it only be beta agonist. Again, dobutamine and dopamine are chemically similar, but dobutamine only acts on your beta receptors and specifically that beta 1 receptor. And it's normally used in cardiogenic shock. Sometimes it can contribute to hypotension as well. We normally use this as a better treatment for those that have decompensated heart failure. So what you'll find is that we talked about our dopaminergic receptors. We talked a little bit about our beta 1 receptors. We talked about our alpha receptors, but we didn't necessarily get into our beta 2 receptors. So that will be our respiratory indications here, beta 2 receptors. So normally our beta 2 receptors respond and cause bronchodilation. So when we take medications that act on beta 2 adrenergic receptors, they're really causing that bronchodilation. Recall that the sympathetic nervous system, when stimulated, causes bronchodilation. So in the terms of respiratory indications, this is a really good medication to use in those that have asthma, because individuals with asthma, they have a hyperresponsiveness and they have this constriction of their vessels in the lungs. So using a bronchodilator will help stimulate those beta 2 adrenergic receptors on the lungs, which will ultimately cause bronchodilation. Again, this is helpful in treating asthma and bronchitis, which both feature the constriction of those vessels in the lungs. It may cause some tachycardia, or it may also worsen atrial fibrillation. So atrial fibrillation is where the heart in the atria, that is the top part of the heart, they're kind of vibrating. And sometimes the heart can vibrate or have high heart rates with AFib, especially when you get into AFib RVR and atrial fibrillation at higher heart rates, or a flutter even. So this is just where the top of the heart is fluttering or moving very fast, and this is a sort of tachycardia. You can have sinus rhythm, or a sinus rhythm what would consider to be a normal rhythm, but it's just a fast rate. So bronchodilators may actually worsen both of those conditions. So it would be very important for you to check your heart rate and check and see if the patient has any dysrhythmias or arrhythmias before giving a bronchodilator. You also want to look at nasal decongestants. Nasal decongestants normally work on your alpha 1 adrenergic receptors, but they don't work on your beta 2 at all. But alpha 1 would essentially dilate those vessels as well. So nasal decongestants specifically work on alpha 1 adrenergic receptors. It's a vessel dilator, Bronchodilators work specifically towards the lungs and they act on those beta 2 adrenergic receptors. So the medications of choice for those beta 2 receptors are your B2 agonist, that's albuterol and salmeterol. And again, they work on those B2 adrenergic receptors on the lungs to help cause bronchodilation. Okay, so here we're talking about our adrenergic ophthalmics and our bladder. So with our ophthalmic solutions, it's used to reduce the amount of intraocular pressure in the eyes. So another way of saying intraocular pressure is high blood pressure in the eyes or intraocular hypertension. This is the same thing inside of the eye. So the thing is that you have to know that your eyes are vasculated. So you can have high pressures in the eyes because of the vasculature that exists in your eyes. So these ophthalmic solutions, it's adrenergic, but they specifically cause vasoconstriction. Now, that may be confusing because what they do, but really the vasoconstriction helps reduce the amount of congestion that is in the eye. So it kind of functions as a decongestant. Same thing in the nose, but instead of it being in the nose, it's in the eyes. So we have different medications that do that. We have epinephrine and phenylephrine, tetrahydrozoline, nephozoline. All of these would help to cause arterial vasoconstriction. As far as the bladder, we've seen this work before, Myrbetriq or mirabegron, and this helps to relax your detrusor muscles in the bladder. So again, when we stimulate our adrenergic receptors, it shunts the bladder from working basically. So when we have compression of the bladder, that means that we're pushing things out of the bladder, specifically urine. So when we relax that detrusor muscle, it actually increases the storage capacity in the bladder because we're not pushing things out. We're actually allowing it to keep what the contents of the urine inside of the bladder. So don't get those confused, okay? So when we have Myrbetriq, it is for an overactive bladder, and when we talk about overactive bladders, that means you're constantly peeing and peeing and peeing. So the stimulation of your adrenergics by the form of Myrbetriq or mirabegron, it helps relax those detrusor muscles. Therefore, you're not constantly having that muscle push that urine out. That muscle relaxes, and therefore you don't feel the need to urinate as much. It also helps to increase that bladder storage capacity. So here are our nursing considerations. For vasoactive alpha adrenergics, you want to monitor blood pressure. Phenylephrine may cause reflex bradycardia. For your vasoactive alpha and beta adrenergics, you want to know that they are titrated. They are weaned up and down based on hemodynamic parameters, and they may cause extravasation in your veins. Vasoactive adrenergic inotropes are also titrated based on hemodynamic parameters, and they may cause extravasation. And then you have adrenergic respiratory indications that may cause tachyarrhythmias or high heart rate arrhythmias, specifically in those that already have tachycardia that exists, or a dysrhythmia such as atrial fibrillation or atrial flutter. You have adrenergic ophthalmic and bladder, and this may cause hypertension, urinary tract infections, which makes sense because you're holding on to the urine that you would essentially be excreting. So that may include bacteria that can cause urinary tract infections. It may cause headache, nasopharyngitis, nausea, and dizziness. Okay, so we talked a lot about our adrenergic agonist or our adrenergic sympathomimetics. They are mimicking the sympathetic nervous system. Now let's talk about those that antagonize the adrenergic or the sympathetic nervous system. Okay, so this means that they are blocking those receptors that we talked about, those alpha receptors, those beta receptors, and those dopaminergic receptors. An antagonist, remember, is something that blocks the action of what would stimulate it normally. So again, we're talking about adrenergic antagonists or adrenergic blockers. So here's our wonderful chart again, and here are the areas that we're talking about. Since we're discussing the sympathetic nervous system, we're talking about the drugs that would inhibit the sympathetic nervous system. So we're talking about drugs that would inhibit pupil dilation, that would inhibit or cause negative ionotropic effects, negative chronotropic effects, negative dromotropic effects. We're talking about medications that will cause bronchoconstriction. We're talking about drugs that in the GI tract will cause vasodilation. So again, we're talking about basically the opposite effects of which the adrenergic system is not stimulated. As it relates to our blockers, our adrenergic blockers, these are drugs that inhibit or antagonize the action of our adrenergic receptors, such as alpha 1, alpha 2, beta 1, beta 2. So, as it relates to our alpha blockers, these particularly with alpha 1 blockers, they block the action of what the sympathetic nervous system would normally do as it relates to the blood vessels, pupil dilation, and urinary retention. So, again, when we talk about our alpha 1 um, blockers, they actually lead to effects such as vasodilation, reduced blood pressure, and we have pupillary restriction. When the alpha adrenergics are stimulated and are not blocked, they produce effects such as vasoconstriction, higher blood pressure, and pupillary dilation. So again, this is the reverse effect. When we have an alpha blocker, we have vasodilation, we have reduced blood pressure, we have pupillary constriction at these sites. And more specifically, it is important to note that it is blocking the action of the sympathetic nervous system. So anytime we talk about a blocker, another name for that is an adrenergic antagonist or a sympatholytic. Sympatho is referencing the sympathetic nervous system. We have lytic, which is inhibiting. Sympatholytic. These are drugs that inhibit the functioning of the sympathetic nervous system. So you want to use an adrenergic blockers, in this case, an adrenergic alpha blocker for hypertension, for hypertensive crisis, which is also known as pheochromocytoma. You want to use this in Raynaud's disease, acrocyanosis, frostbite, and in the case of vasopressor extravasation. So vasopressors normally cause extravasation if they're not in the vein appropriately, and that's an injury to the site where the vein is on the inside and the outside of that vein. So giving a blocker inhibits the action of the drug, which ultimately produces an antidote for that extravasation. Again, in the case of frostbite, normally your vessels have constricted and are frozen in that area. So giving a alpha blocker actually helps with vasodilation in that area. Acrocyanosis, you have the bluing of the body systems. Again, you have that vasodilation to help open up that blood flow to those areas in order to help perfuse that area. So again, with hypertensive crisis, even if the blood pressures are high, you normally use a alpha blocker to help bring the blood pressure down, and of course in hypertension. So the thing with hypertension and hypertensive crisis is that hypertension is over the long term and it is a chronic effect, whereas hypertensive crisis is more acute and a sudden stimulation of very high blood pressures, and of course that could lead to stroke. So alpha 1 adrenergic blockers have the opposite effect of the sympathetic nervous system. So it again decreases that muscle contraction, it vasodilates, it has pupillary constriction, and it also causes you to urinate. So you do treat hypertension with this, high blood pressures, and you also treat benign prostate hyperplasia, where your prostate is swollen to the point where it's preventing you from peeing. This actually helps you urinate. So The medications that are considered alpha 1 adrenergic blockers are your prazosin, terazosin, and doxazosin. And again, that is used to treat hypertension and BPH, or benign prostatic hyperplasia. As I've mentioned before, these alpha blockers are inhibiting the actions of the sympathetic nervous system. So we have several as our examples here. We have doxazosin, also known as Cardura, and what this does specifically is reduce peripheral vascular resistance and blood pressure by dilating both arterial and venous blood pressures. So it helps to control blood pressure overall. You always want to take this medication with food. You want to take this medication consistently, and you never want to abruptly stop this medication. We have a medication called phentolamine, also known as Regitine, and this is a alpha blocker that reduces the peripheral vascular resistance, and it is also used to treat hypertension. But most commonly, it is used to treat extravasation of vasoconstricting drugs, such as your vasopressors. That's that norepinephrine, epinephrine, and dopamine, which, when given intravenously, can leak out of the vein. So again, that extravasation causes injury to those extremities by which those veins exist. So in order to give a antidote, if you will, the Regitine serves as an antidote for norepinephrine, epinephrine, dopamine extravasation. Again, if it's not correctly positioned in that vein, you do have conditions called extravasation. And then you have tamsulosin. This is also known as Flomax, and you'll see this a lot in the treatment of benign prostatic hyperplasia. And what this does is that it blocks the alpha adrenergic receptors on the smooth muscle within the prostate and bladder. So its action is an alpha 1, but its direct action is on that prostate and the bladder. So as far as your side effects, of course, you can have nausea, dizziness, priapism. You can have headaches, diarrhea, urinary frequency, which is kind of what you want this to do in the case of Flomax, because you're trying to get the individual to urinate. You may have drowsiness, all of these things. So just make sure you review those side effects as it relates to these alpha blockers. So you may remember this slide. This is the slide that we talked about earlier when we were kind of discussing the basic concepts of our medications. Well, I just want to review this slide once again because it does drive our points home when it comes to our adrenergic antagonists, or our beta blockers here. So again, beta blockers normally are drugs that stimulate our beta receptors. In this case, we have a beta blocker that stimulates B1 receptor, which deals directly with the heart. So it does slow down contractility. It slows down the conduction through the AV node, which ultimately leads to a decrease in heart rate, decrease in cardiac output. It decreases your cardiac preload and BP, and also decreases your O2 demand, because we are consistently blocking that sympathetic nervous system. And again, if we look over at the kidneys, the beta blockers also decrease the amount of renin in the kidneys. Again, the kidneys have a lot to do with our blood pressure regulation. So when we have a beta blocker, you do see a decrease in renin, which ultimately helps to release aldosterone. Aldosterone is normally reabsorbed, or helps with water reabsorption and sodium reabsorption. So when you see a decrease in that, you normally see sodium and water follow each other. So ultimately, you will have a decrease in blood pressure. So again, I just want you to review this slide and just make sure that you're understanding that when we have beta blockers, it does stimulate the decrease of blood pressure through the heart in these areas, and it also decreases blood pressure through the kidneys in these areas. As it relates to our beta blockers, they inhibit the action of the sympathetic nervous system. That means they are decreasing that action. In our top corner here, we have the mechanism of action. And as we can see, this green beta blocker is the drug, and it's competing for the spaces that normally norepinephrine and epinephrine would normally sit in this beta receptor. Normally our beta blockers, they end in LOL, that's LOL, so we have atenolol, we have nebivolol, carvedilol, metoprolol, propranolol. All of these are beta blockers because they end in lol. But the thing to remember about beta blockers is that you have cardioselective beta blockers, which means that they only are attracted to beta 1 receptors, which specifically affect the heart and kidney. And then you have non-selective beta blockers that affect both beta 1, beta 2, and or beta 3, depending on the mechanism of action. But really, we want you to focus on the beta blockers that are cardioselective, and that's listed here, that atenolol, metoprolol, carvedilol, and nebivolol. They stimulate that beta 1 receptor, which directly acts on the heart and kidneys. Then you have the non-selective that work on beta 1 and beta 2. And recall, the beta 2 receptors are specifically on the lungs. So they help with that bronchodilation. Well, in this case, they help to cause bronchoconstriction because they are inhibiting the action of what a normal sympathetic response would be in the lungs. So that's what these non-selective beta blockers do, which brings up the point that if you have a individual that has asthma, it's not good to give them a non-selective beta blocker because of the effects that it has on those beta 2 receptors. A non-selective beta blocker will inhibit the sympathetic response at the beta 2 receptor, but what that ultimately means is that there is no bronchodilation. In fact, it'll further cause bronchoconstriction, bronchospasm, which is not good. So again, just make sure you look at the differences between the beta 1, beta 2 receptors and their action as it relates to a beta blocker. So beta blockers, of course, do cause adverse effects, and they are known to be contraindicated in those with uncompensated heart failure, heart block, bradycardia, pregnancy, severe pulmonary disease, Raynaud's disease, cardiogenic shock. They normally say that beta blockers shouldn't be withdrawn abruptly. So that goes back to that don't stop any medication abruptly without speaking with your physician, because they do have to be tapered off. Again, beta blockers work on the sympathetic nervous system, so they further decrease the action of the sympathetic nervous system. So the common adverse effects you may see is hypotension, bradycardia, fatigue, dizziness, headache, sleep problems, hallucinations, depression. But there's a very dangerous thing that we also need to look at, and that's called hypoglycemic awareness. So when you have the sympathetic nervous system and that sympathetic nervous system is stimulated, you have an increase in your blood sugars. That's to help with energy, to help with the fight or flight response. Well, when you take beta blockers, it's decreasing, and it has that reverse effect on your blood sugars. So the first thing is that when you have your blood sugars lower than normal, you don't necessarily have the effects that would normally present with low blood sugar. So just as an overview, when you have hypoglycemia, normally you experience palpitations, tachycardia, you may have some anxiety and tremors, but all of those would be more related and similar to what would happen in your sympathetic nervous system response. Higher heart rates, your heart is beating faster, palpitations. Well, because your beta blocker is essentially lowering your blood pressure and your heart rate. Your heart has been slowed down as a result of this. So you're not going to experience the warning signs of what hypoglycemia normally presents itself as. So you have to pay special attention to those in the diabetes population that are also on beta blockers. And you have to be careful about that because they won't know that their blood sugar is low and ultimately can fall into a coma unexpectedly because they don't know that their blood sugar is approaching a dangerous low level. So when you discuss these side effects, make sure you pay attention to the other comorbidities because that would be a great teaching point for your patients as it relates to the adverse effects of metoprolol. So again, it is contraindicated for those in asthma, particularly with a non-selective beta blocker because of the furthering of bronchoconstriction, bronchospasm because of that beta 2 receptor, and it may result in shortness of breath. And you do see other metabolic changes. So again, just make sure you understand the awareness with hypoglycemia as it relates to just any beta blocker. So these are other selected beta blockers. Again, we have our metoprolol. Metoprolol is a beta 1 blocker, so it's cardioselective towards the heart with that beta 1 receptor. And you do have two types that you have to be on the lookout for. Make sure you look out for the extended release tablets, which you cannot crush because they're extended release and they are structured to go over long periods of time. Versus metoprolol tartrate, which you may be able to crush if it's in the appropriate form. So again, make sure you look at the differences of that. Make sure you know that propranolol is a beta 1 and beta 2 blocker. Beta 1 particularly for the heart, beta 2 for the lungs. So this is a non-selective beta blocker because it works on the heart, kidneys, and lungs on both beta 1, beta 2 receptors. And we are recently discovering the beta 3 receptors as it relates to the adipose tissue. But just really understand the beta 1 and the beta 2, and it's non-selective. And then normodine, or also known as labetalol, this is also non-selective because it can act on the alpha 1 and beta 1 receptors. Again, this is a beta blocker that works on both of those receptor sites, and they normally treat hypertension, myocardial infarction, heart failure, and arrhythmias. So just make sure you understand the differences. You have cardioselective medications, beta blockers such as metoprolol, and then you can have non-selective such as propranolol and labetalol, and they even cross over different receptor sites. You can have non-selective for beta 1 and beta 2 receptors, or non-selective for alpha 1 and beta 1 receptors, and so on and so forth. Regarding your nursing considerations, alpha blockers may cause palpitations, orthostatic hypotension, tachycardia, nausea and vomiting, incontinence. Non-selective beta blockers may cause more heart blocks, bradycardia, heart failure, decreased level of consciousness, delayed hypoglycemia recovery or masked hypoglycemia, impotence and wheezings or bronchospasms. You have selective beta blockers, and particularly to the heart, and it may cause heart blocks, bradycardia, heart failure, decreased level of consciousness, delayed hypoglycemia recovery, and mass hypoglycemia, impotence. As far as the management of beta blocker toxicity, you want to do symptomatic and supportive care. This means that the heart rate has gotten low to where you've had too much of a beta blocker. So you have to think about what this is doing to the heart. The heart is slowing down, so you may have to pace the heart or put someone on a machine. Normally it is the life-saving machine. Normally we have life packs and Zols that we use to help pace a patient, but you'll have the pads on the patient and you'll literally stimulate their heart rate back up to an appropriate level. So this is what we call pacing. You may have to use medical intervention such as atropine. Atropine again is it's a cholinergic antagonist, but we want to make sure that we use atropine in symptomatic bradycardia. This is one of our ACLS life-saving medications as well. You have isotonic fluids. This is just normal saline or lactated ringers that will help boost the fluid volume status and increase blood pressure in a patient. And of course, you can use a adrenergic vasopressor such as dopamine. You want to make sure that you always have continuous EKG monitoring, especially if you have to manage beta blocker toxicity. You want to look at drug interactions such as your QTC prolongation. That's especially important when we give medications such as Zofran. And you also want to do electrolyte monitoring, specifically with your sodium, your potassium, and your magnesium levels.